I have nothing to disclose. As you view this presentation, consider the following important points regarding testing. How is the testing going to be used in your practice? When should the tests be used? How will results impact patient management? We will start with a case presentation. I will then give you updates to the 2015 WHO classification of lung adenocarcinoma. We will discuss the handling and reporting of small biopsies, and we will finish with take-home points. The case is that of a 73-year-old woman who was found to have ground-glass opacity in the right upper lobe lung about 10 years ago. This ground-glass opacity was slowly increasing in size and intensity. A wedge resection was performed. Here you can appreciate the CT imaging studies which show the ground-glass opacity in the right upper lobe lung. On wedge resection, we appreciate one area that looks abnormal because of interstitial thickening and a more blue color. This area has a diameter of 2.3 centimeters. On higher power, on the lower left-hand side, we appreciate unremarkable lung parenchyma and then an abrupt onset of atypical cells lining thickened interstitium. There is a cellular crowding as evidenced by cellular overlap and also focally pseudostratification. The interstitium is slightly thickened due to some fibrosis and chronic inflammatory cells. What diagnosis would you consider? This would be an adenocarcinoma in situ. The 2015 WHO classification added adenocarcinoma in situ, minimally invasive adenocarcinoma, and invasive mucinous adenocarcinoma. Terms such as bronchoalveolar carcinoma, mixed subtype adenocarcinoma, and clear and signet ring cell carcinoma were discontinued. Furthermore, lung adenocarcinomas were classified as pre-invasive lesions, including atypical adenomatous hyperplasia and adenocarcinoma in situ, minimally invasive adenocarcinoma, and invasive adenocarcinoma. Let's start with atypical adenomatous hyperplasia. These are small proliferations of mildly to moderately atypical type 2 pneumocytes and or Clara cells that line usually slightly thickened interalveolar septa. There are in general gaps between atypical cells, and these areas are not seen by imaging, therefore they are in general not biopsied. If you see a biopsy that shows atypical cells lining thickened interstitium, this will not be atypical adenomatous hyperplasia since these lesions are not biopsied. They are cured if resected, and as you can imagine, there is a morphologic continuum between atypical adenomatous hyperplasia and adenocarcinoma in situ. Here's an example where you can appreciate slightly thickened interstitium that is lined by atypical cells. These atypical cells respect each other and there are some gaps in between. This is an example of AAH. Adenocarcinoma in situ is usually an incidental finding on CT imaging studies. It shows as a non-solid, circumscribed ground glass nodule that is slowly growing. On close examination of a specimen, adenocarcinoma in situ is usually a poorly defined nodule. Adenocarcinoma in situ and minimally invasive adenocarcinoma share some defining features, including its size. It should not be larger than 3 centimeters. There also should be no pleural or vascular invasion, and there should be no spread through the airspace. Also, they are usually non-mucinous. However, rarely they can be of mucinous type. Adenocarcinoma in situ should not have any stromal invasion and should have a purely lipidic growth pattern. Here's an example where we see the atypical lining cells of slightly interstitial thickening, and these cells have overlap and also pseudostratification. If we diagnose an adenocarcinoma in situ on a resection specimen, the entire tumor should be sampled because the invasion can be very focal. There are prospective randomized studies going on to identify whether sublobar resection, such as wedge resection or segmental resection, might be sufficient for treatment. The current TNM or HACC staging system does not address adenocarcinoma in situ. For the upcoming TNM classification, it is proposed to use TIS and in parentheses adenocarcinoma, but currently we have to stage these tumors by size. Minimally invasive adenocarcinoma is also in general incidentally found on CT imaging, where it is usually identified as a peripheral lesion. On CT scan, it presents as a part solid nodule with a solid component, which is usually less or equal to 0.5 centimeters in largest diameter. Again, minimally invasive adenocarcinomas are defined by size, which is less than 3 centimeters, and there should be no pleural or vascular invasion and no tumor spread through air spaces. There is a predominant lipidic growth pattern, and in contrast to adenocarcinoma in situ, we do find focal stromal invasion, which should not be exceed 0.5 centimeters. Here's an example of such a tumor. We appreciate a 0.8 centimeter nodule. On low power, there is one area where glands appear to be rather complex. On high power, these small glands are in a desmoplastic stromal reaction. And this area is less than 5 millimeters. In fact, it is only 3 millimeters, and therefore it is defined as a minimally invasive adenocarcinoma. In these tumors, the tumor cells focally infiltrate myofibroblastic stroma or desmoplastic stroma, and the invasive component is comprised of any histologic type other than lipidic growth pattern. Also, there should not be any tumor necrosis. Minimally invasive adenocarcinoma is also not addressed by the current TNM or HACC staging. However, for the upcoming HACC staging, it is proposed to be used a PTMI. Currently, we have to go by tumor size. Invasive adenocarcinomas can be comprised of different growth patterns, including acinar, papillary, micropapillary, lipidic, and solid. Cribriform pattern is also a growth pattern of invasive adenocarcinomas that has been recently described and therefore is not in the current WHO classification. These growth patterns should be subtyped in 5% increments. Here's a typical invasive adenocarcinoma. An acinar growth pattern, as you all know, is classified by these acinar glands that are lined by the neoplastic cells. Usually, there is a quite complex architecture to these neoplastic glands. Micropapillary pattern are comprised of micropapillae that are in these neoplastic glands. Sometimes they can be dislodged into the lumen of the glands. However, they do not have fibrovascular cores. Papillary pattern are comprised of papillae which have fibrovascular cores that are lined by neoplastic cells. This pattern sometimes can be difficult to be distinguished from an adenocarcinoma in situ, and therefore we always have to watch out for these papillae. On high power, we recognize the fibrovascular core that is lined by the neoplastic cells. A solid pattern of adenocarcinoma can be difficult to distinguish from a solid pattern of a squamous cell carcinoma. Therefore, if in doubt, immunostains should be performed. In this case, the neoplastic cells were positive for TTF1, indicating a solid pattern of lung adenocarcinoma. Here's an example of lipidic growth pattern. We appreciate the preserved lung architecture that is lined by the neoplastic cells. On higher power, again, the thickened interstitium lined by neoplastic cells, indicative of Lepidic growth pattern. In another area, there was clearly invasion, and this area was larger than 5 millimeters. The cribriform pattern reminds us of the cribriform type of ductal carcinoma in situ in the breast. We appreciate the tumor cells and the cookie cutter areas of glands. Prognostic parameters of lung adenocarcinomas include stage, tumor grade, invasion, but also subtype, and specifically the presence of micropapillary, solid, and cribriform components, even if these are minor components because they have a worse outcome. Lymphovascular invasion and likely tumor spread through air spaces are also prognostic parameters. Here's a study that shows the prognostic value of invasion and subtype of adenocarcinoma. As you can see, adenocarcinoma in situ and minimally invasive adenocarcinoma have the best outcome, while cases of micropapillary and solid subtype have the worst outcome. About 70% of patients with lung cancer present at an advanced stage, and therefore small biopsies might be the only tissue we have available for further studies. Therefore, tissue preservation is key. We often have to perform immunohistochemistry for subtyping of non-small cell lung carcinoma, which is important for treatment. However, we should limit the immunohistochemical panel to only a few stains if we can. A panel might be comprised of TTF1 and P40 or CK5/6. If your immunostains lab is capable of doing dual stains, some appropriate combinations might be P40 and napsin or CK5/6 and TTF1. Also, if you have more than one tissue core available, you can divide these cores into multiple blocks. We do have to confirm that tumor tissue is actually present in each block by an H&E, but for ordering immunostains, we might only use one of the blocks. Also, if we order immunostains, we always get unstained slides in case additional stains or molecular studies need to be performed. There are certain diagnoses that we cannot make on small biopsies, and these include adenocarcinoma in situ, minimally invasive adenocarcinoma, large cell carcinoma, and adenosquamous cell carcinoma. Because of their definitions, they require sampling of the entire tumor. If a biopsy only shows Lepidic pattern, this might be signed out as a well-differentiated adenocarcinoma with Lepidic growth, and then see comment, and a comment might state that the distinction between invasive adenocarcinoma and adenocarcinoma in situ should be reserved for the resection specimen. What is the reason? The reason is that we do not know exactly where the biopsy was taken from. If you look at the left large arrow, this biopsy is likely taken only from the ground glass opacity, which is likely only the in situ component. However, if the biopsy was taken from the side of the small right arrow, this is the solid component which likely will show the invasive carcinoma. According to the current WHO, small biopsies, if you need stains to differentiate adenocarcinoma from squamous cell carcinoma, these biopsies should be signed out as non-small cell carcinoma, favor either adenocarcinoma or squamous cell carcinoma, dependent on what your stains showed. Here's an example of a needle core biopsy that shows clusters of tumor cells in a desmoplastic stromal reaction. On high power, these cells are large and do have some cytoplasm, indicating non-small cell carcinoma. However, there is no keratinization or gland formation that could help us to further subtype this tumor. Therefore, immunostains were performed, which show that the neoplastic cells are positive for CK5/6 and negative for TTF1. Therefore, this case was signed out as non-small cell carcinoma, favor squamous cell carcinoma. In summary, subtyping of adenocarcinoma is important for prognostic purposes. Adenocarcinoma in situ and minimally invasive adenocarcinomas have an excellent prognosis, while micropapillary, solid, and cribriform components have a worse prognosis. Tissue preservation on small biopsies is crucial.